The Assessment of Factors Associated with Delayed Recovery, a Biopsychosocial Paradigm, by Daniel Bruns and John Mark DeSorbio. This is presented by Dr. Daniel Bruns and sponsored by the American Academy of Physical Medicine and Rehabilitation. The goals of this presentation are to become familiar with the biopsychosocial model and how it differs from the biomedical model, to understand the biopsychosocial model and neurophysiology of pain, to understand chronic pain syndrome as defined by comorbidities, and how to utilize psychological assessment as one means to reduce pain-related disability. Before we begin, I need to report one conflict of interest. That is, Dr. DeSorbio and I are co-authors of two of the psychological tests that are mentioned, the BHI-2 and BBHI-2. Pain assessment seems pretty straightforward. Most doctors ask their patients on a scale of 1 to 10, rate your pain. But the patient says, now, 1 to 10, so if I have 0 pain, that's a 1, or do you mean on a scale of 0 to 10? And by the way, what is a 10? My other doctor says 10 means pain so bad you want to die, but I'm not suicidal. So what do you mean by a 10? And do you mean my pain right now? Or when I stand up, or when I bend over? Or my average pain in the last week? And do you mean my back pain, or do you mean my headaches? Or what do you mean? Pain assessment is not as simple as it looks. When you think about it, pain is a really interesting phenomenon. It's the most common reason why people come to see a physician. Something hurts. Studies have shown up to 80% of all patient visits involve some complaint of pain. Ironically, though, in a study of U.S. medical schools by the Institutes of Medicine, no U.S. medical school required a class in pain, and only about 3% even offered an elective class in pain. It seems like a remarkable oversight. So often in treatment, though, you have to face that dread question when the patient asks you, so do you think my pain is all in my head? What do you say? Are there really two types of pain? Real pain and pain that's in your head? This is a point of view that actually goes back to the year 1700 when it was proposed by Descartes. Today, this model of pain is called the biomedical model. It presumes that physical health and mental health are separate and distinct. The biomedical model assumes that physical symptoms are either real and biological or not real and in your head. Here the phrase "in your head" infers that the patient is either lying or crazy. Either they're lying about their pain to get money or malingering, or they just imagine their pain due to some form of psychopathology. So, two forms of pain separated at the neck. While this interpretation of pain is a popular cultural construct, it is not based on science. Evidence has consistently shown that the biomedical interpretation of pain is wrong, and that there are often explanations for some of the mysterious symptoms that patients report. If we have a better understanding of pain, it will create more opportunities for effective interventions. So what have we learned from science? Some of the recent scientific findings about pain seem really counterintuitive at first, but as you think about them, they make a lot of sense. Culturally, we distinguish physical pain from emotional pain. But that's not true. Neurological studies show that pain and emotion are wired together. After struggling with this for years, in 1994, the International Association for the Study of Pain published their definition of pain. What they concluded was pain has a dual nature. In part, pain is sensation, like a sense of touch or smell. But in part, pain is an emotion, like anxiety or depression. Again, that seems counterintuitive at first, but suppose you were doing an examination on a patient with a shoulder injury, and you're testing the patient's range of motion and lifting the patient's elbow when the patient exclaims, "Ouch, damn it!" So what did you just hear? sensation, but also emotion. I mean, the patient sound angry. So often, the experiences of pain and emotion are so intertwined that you cannot separate them. It's that way neurologically too. Pain and emotion are inseparably intertwined. The close interrelationship between pain and emotion is confirmed by fMRI studies of the brain. The brain's pain center has been identified as the anterior cingulate cortex. Activity there can be triggered by physical pain, of course, but also by social pain or rejection, by seeing a loved one in pain, or by imagining pain. Thus, the brain's pain center is activated by both physical and emotional pain. Both of these types of experiences share the same neural circuits. It is now believed that comprehensive pain assessment should be biopsychosocial in nature. And this is the origin of the biopsychosocial model. This model hypothesizes that to assess pain, you need to look at biological, psychological, and social components. The biological component focuses on whatever the injury was. The psychological component on variables like mood or the patient's personality, and social variables such as, is family support present? Litigation? Does the person like their job? A comprehensive assessment of a patient with pain needs to include all of these components. To understand the biopsychosocial model, we need to begin with biology. We generally think of pain as a single sensory experience, but actually that's not true. Pain is a complex sensory experience which is informed by a variety of sensory organs and neural systems. An important component of the pain sensory system is the nociceptor, a sensory receptor designed to detect tissue damage. There are various types of nociceptors, though, and these nociceptors interact with other sensory receptors and other neurological systems. To understand this better, let's switch to a schematic view. Pain is not one sense, but many. There are nociceptors for hot and cold, for mechanical pain like being pinched, for chemical pain like a bee sting. There are also these things called sleeping sensors which do nothing at all. That is, until they're activated by inflammation. Pain sensory receptors are organized into two parallel but distinct pain sensory systems. One is called first pain sometimes, and it's more closely associated with acute pain. This sensory system utilizes A delta nerve fibers and produces a sharp localized pain. In contrast, there is a second pain sensory system which is more closely associated with chronic pain. These pain sensations are conducted by C fibers and have polymodal receptors. These produce an achy, diffuse pain. So, if you closed your eyes and I stuck you with a needle, you could say, for example, that I just stabbed you in the right index finger just to the left of your fingernail. That would be first pain. You could say exactly when it started, what it felt like, and when it stopped. In contrast, second pain is more diffuse. Second pain is hard to describe. It's hard to localize. It's like the patient who says, my back hurts and the pain goes down into my leg and up my back, and it's this burning, aching, tight feeling. That's second pain. It's hard to localize. It's hard to describe. These two pain sensory systems follow separate paths to the brain. Along the way, these nerves could be pinched or cut, and that could produce neuropathic pain. And pain signals are also altered in the spine. Here, glial cells can amplify pain experiences by the production of pain neurotransmitters, and also inhibitory signals from the brain can increase or decrease pain signals. To be more accurate, though, this is not pain yet, but rather just activity among nociceptive nerves. This nerve activity does not become pain until it reaches the brain. The first pain sensory system is the simpler of the two. Here, the acute pain nerve fibers travel to the somatosensory cortex. This part of the brain controls sensation and movement. And first pain sensations are associated with a withdrawal reflex. That is, you touch a hot burner, you jerk your hand away. When people talk about pain, they are often referring to this part of the pain sensory system. The second pain sensory system follows a more circuitous path through the brain, starting with the brainstem, where it's associated with arousal. The patient says, "I can't sleep," with muscle tension and spasms. It then travels on to the limbic system, where it's associated with emotion like depression, anxiety, or anger. It's also associated with a weakened immune response. Over the course of time, people start to think about their pain. Will I get better? This is really terrible. These thoughts begin to shape pain. Pain also begins to impact the patient socially with how they cope with the world. Will I have a job? How will I provide for my family? And over the course of time, the patient begins to build memories of their pain. They say, "I am so sick of this. This has been going on for years now." And all of these experiences are integrated in the pain center of the brain in the anterior cingulate. With second pain in particular, the brain can become sensitized over time, and this is called central sensitization. And in the spinal cord, a parallel process called wind-up occurs. If we put both of these sensory systems together, it looks like this. And let's add one more thing, the downward arrow, because the brain regulates pain with descending neural inhibition. So thus you have two competing forces, wind-up and sensitization, increasing pain, and descending neural inhibition, decreasing it. So let's summarize. This is acute pain. You get stuck by a needle, you say, "Ouch!" You feel exactly where it is when it starts, and you jerk your hand away. Again, when we think about pain, we're often thinking about the first pain half of the pain sensory system. In contrast, chronic pain is like this. Here the patient may say something like this: "Doc, the pain is killing me. You gotta do something. I'm sick of it. I can't stand it. It's overwhelming. I can't live like this. You gotta give me something stronger for the pain." Ever hear that before? We are no longer talking about sensation alone, but also about emotions, cognitions, memories, and a desperate need for relief. When you hear that, that is the other pain sensory system in operation. What we have learned from scientific studies is that chronic pain begins to rewire the brain. The connection between brain regions involved in perception, emotion, arousal, judgment, cognition, and other factors are changed by the long-term effects of severe pain. In the diagram here on the left, you can see how the brains of patients with CRPS and without CRPS function differently. So what have we learned from science? Chronic pain, over the course of time, remodels the central nervous system. Let's try a little experiment. Take your fingernail and scratch the back of your wrist. Feels pretty good. Now keep doing that for the next 12 hours. Actually, don't do that. It will become unbearable as the sensory system winds up. That will include wind up in the dorsal horn of the spinal cord and also in the brain. And over the course of time, this will forge new brain connections, as we've seen from the previous studies. As time goes on, chronic pain can start to look more and more like a neurodegenerative condition. There is decreased gray matter in the prefrontal cortex, and the brains appear to age rapidly on imaging. Also, a systematic review has shown that chronic pain is associated with the onset of memory impairment. Over the course of time, the CNS remodels itself so that pain becomes less closely associated with sensation and more about arousal, emotion, memory, and beliefs. So does this happen at 3 months or 6 months? Actually, that's not the case. Sometimes it can happen quite quickly or not at all. So it's a mistake to think about this in terms of time. A recent study found that just one night with no sleep at all can create pain hypersensitivity. So just after one night of no sleep, high stress, you can start seeing the appearance of central sensitization. In other cases, some patients go a long time with pain that presents in a more acute pain-like fashion. Thus, it's possible to have persistent acute pain. If we think about this from a neurological perspective, you might think of it this way. Acute pain is a localized perception of actual or potential tissue damage, which is associated with a withdrawal reflex. That's first pain. In contrast, second or chronic pain is a more complex process. It may evolve over days, weeks, or months, and is often associated with illness symptoms and seeking care. So how do you know when chronic pain is present? The literature defines chronic pain again in terms of time. After 3 months, 6 months, maybe after a year, but that's not really helpful. There's no treatment for time. There's nothing you can do about that. And it overlooks the fact that sometimes patients have persistent pain, which looks more like the product of the first pain sensory system. That is, it's well localized and not associated with distress. But on the other hand, there's some patients that look chronic within days of their injury. And if a patient is distressed enough, the second pain sensory system can get wound up in a short period of time and produce a number of comorbidities. So I think it's more helpful to think about the symptom constellations that you see and not just simply look at time. Any cutoffs we make based on time are purely arbitrary. We have been thinking scientifically up to now, but I'd like to think more clinically for a bit and think about, in a clinical setting, what do chronic pain patients say and what's the actual explanation for what's going on? Now suppose you had a patient with a back injury who continued to complain of pain after an L4, L5 discectomy. You investigated these complaints using every conceivable test, but there are no objective findings at all. And still the patient insists, "Doc, I know there's something wrong. I can feel it. I need surgery. You gotta do something." Is the patient crazy? Faking? Is it all in his head? Again, this is not a helpful way to think about what is in fact a complex sensory disorder. Think of it this way. Suppose I got my trusty camera strobe and flashed you in the face. What would happen? You would of course see a blindingly bright light, but what about after that? A couple seconds later you'd notice a blue dot floating around in front of your eyes, the after image of the strobe. I should point out that there is no blue dot in the room. The blue dot is not real. The blue dot is in your head. If you would persist about seeing the blue dot, I could send you to an MRI and we could see your eyes are fine. There is no blue dot. It is in your head. Your brain is fine. Your eyes are fine. The same thing would happen if you went to a concert and sat next to the speakers and it was really loud and you got home and your ears were ringing. Now, there is no actual bell tone in the room. The ringing is in your head. It's not real. Or is it real? Well, there is no blue dot in the room. There is no bell ringing, but it's a real sensory phenomena. And in the same way, sometimes after an injury, when a patient is in pain, and especially if they're highly distressed, chronic pain can be like the blue dot of pain. It can be a powerful sensory afterimage that persists after the original injury is healed. So the patient isn't crazy. They're not malingering. This is a sensory disorder. Sometimes patients will say, "So you think my pain is in my head?" I say, that's just a silly way of looking at this and not at all helpful. Your brain is involved in everything that you experience. So of course your brain has some involvement. It has some involvement with everything you think and feel. Doesn't mean it's not real. If we put your brain to sleep under general anesthesia, you wouldn't feel any pain because, well, your brain is asleep. So of course your brain is involved in pain. That's how anesthesia works. One time I actually had a patient say to me, "So are you saying my migraines are all in my head?" I said, "Well, where else would they be?" Just because something occurs with brain involvement doesn't mean it's not real. The brain is a real organ. I tell patients you have a pain disorder. Your central nervous system is involved. It's a real condition. It has real treatments. We will help you with that. Patients with chronic pain are more likely to say, my pain never changes. One of the most startling findings from chronic pain research is that in many patients with chronic pain, they no longer feel their pain. Now that sounds just impossible. Let me use an example. We're going to have a pop quiz. Get out a pencil and a little sheet of paper. Here's the question. Are you male or female? Write down your answer. Now to answer that question, did you do it from memory or did you check? I'm guessing you did that from memory. You know the answer. You don't have to check. And a lot of patients with chronic pain do the same thing. They don't have to check from a sensory perspective. They know their pain is a 10. Patients with chronic pain come to hate their pain. They don't want to feel it, but they remember how bad it is. They know how bad it is. And so the response is based on their beliefs, not sensory information. Paradoxically, some psychological therapies, like mindfulness, are designed to help patients with chronic pain feel their pain again, because if you don't feel it, it can't change. Also, if you don't feel it, you can't tell your doctors what makes it better or worse. Another phrase I've heard over the years from patients with high doses of opioids is they still have a pain level of 10, but say they want to take opioids because they're helpful. And I said, how can they be helpful if your pain is still a 10? They say, well, they don't reduce my pain, but they take the edge off. Where is the edge of pain? I must have missed that day in anatomy class. You know, when I hear patients saying this, though, that opioids take the edge off, I think they're describing something real. Opioids produce a certain amount of euphoria, and affective distress is part of chronic pain, and so I think opioid euphoria may offset some of their emotional distress. That's a comorbidity. But that means they're taking opioids not for pain relief, but for emotional benefit, and there are better medications for that. Some patients with chronic pain exhibit extraordinary pain behaviors upon examination. Sometimes the phrase exquisite pain sensitivity is used. But this is a sign that the pain is bogus. Sometimes patients do exaggerate. There might be various incentives for them to do so, either by gaining access to disability pay or to opioids. But there are other reasons too. There's been some very interesting research about how adverse childhood experiences can influence the patient recovery process. Some patients really don't like having to take off their clothes and having a stranger touch them. It can trigger a powerful fear reaction, and these patients may react strongly to being touched out of distress, not pain. For patients like that, having a nurse present or telling patients what you're going to do before you touch them can help. Well, we've spent some time now talking about the biological aspects of pain, but I want to switch to assessing the psychosocial aspects of pain, the other part of the biopsychosocial model. To do so, I'd like to overview some psychological tests for pain. What can psychological assessment accomplish? It can answer questions like, will a patient adhere to treatment, abuse opioids, return to work, or be satisfied with surgical outcome? Now notice the first three things here are behaviors, like returning to work or adhere to treatment. The last one is a feeling, being satisfied. A lot of outcome variables are behavioral in nature. So how good are psychological tests? This question was answered by a massive study conducted by Meyer in 2001. By massive, I mean it reviewed 125 meta-analyses and 800 other studies, and came to a general conclusion that overall, the science behind good psychological tests is equal to that of good medical tests. So these two tests, psychological and medical, are about equal in their ability to diagnose and predict outcome. And in some cases, psychological tests are better than MRIs and medical tests at predicting medical treatment outcome. That is because, as we just saw in the last slide, a lot of medical outcome variables are behavioral. What does the patient do? How do they feel afterwards? Are they satisfied? Psychological variables. As a physician, you of course know the FDA standards for medication. Is it safe and effective? Psychological tests have standards too. Is it standardized? That's one of those terms which we have encountered in our lives. I venture to say all of you have taken a standardized test, and they're different than classroom tests. But what does that term mean? Standardized. There are some terms that we will need to define. First is the term psychometrics. This is the field of science devoted to the measurement of mental states, behavior, and abilities. It's part mathematical methods and part research methods. Now this field sounds kind of out there, but it's actually something we encounter almost every day. It's almost impossible to watch the news or read a magazine without encountering some phrase like, a survey of U.S. citizens found that 54% blah blah blah. Scientific surveys have shown an uncanny ability to assess the sentiments of a population. They can predict elections, predict what people will buy, what they're going to do. Scientific surveys use psychometric methods to survey populations, and based on just what 700 or 800 people say, they can predict what the country thinks. It's really kind of remarkable. In a similar fashion, standardized psychological tests use the same principles to assess individuals. You can assess a person's mood, personality, or predict how they will respond to a particular medical treatment. As you will recall from the Meyer study, these tests are scientifically sound and can sometimes be very effective in predicting medical treatment outcome. So what is a standardized test? It's a test developed in accordance with the book shown here, called The Standards for Educational and Psychological Testing. This book is one of the most extensively peer-reviewed documents in all of science. For the 5th edition of this work, there are 39 expert reviewers, and over 75 organizations offered reviews as well. This produced over 8,000 pages of peer review comments for a 200-page book. So this is the work that has undergone extensive scientific scrutiny. This work sets forth the standards for what a psychological test should be and how it should be developed. So, are all psychological questionnaires standardized? Obviously not. Most aren't. If you're going to use questionnaires, though, to assess patients, and especially if you're going to base decisions on it, you should understand the level of science behind the test that you are using. Now, there are some non-standardized screening questionnaires that can be helpful, and that can be useful in a number of purposes, but they're not the same thing as a standardized test. There's a big difference in terms of the level of science and scrutiny that they've gone through. Unlike medical products, the FDA does not approve psychological tests. This traditionally has been done in the private sector by an institution called the Burroughs Institute. Since 1938, they've performed peer reviews on standardized tests to see if they meet acceptable psychometric standards. If a test has been formally standardized, you can usually see a review of it at the Burroughs website, listed here. These peer reviews are then published in a work called the Mental Measures Yearbook. Another handy resource was published by the Colorado Division of Workers' Compensation, which reviewed psychological tests for chronic pain. This can be downloaded from the link below. This provides a very succinct overview of a variety of tests, standardized and non-standardized, and lists their characteristics, strengths, and weaknesses. If you review guidelines for chronic pain, some talk about psychological assessment, and some go on to discuss particular psychological tests. Of those that do, you will generally see these 8 tests. All of them are standardized. These tests fall into 2 broad categories. Some are psychiatric tests. These are tests designed to measure psychiatric conditions such as depression, psychosis, personality disorder. These tests were designed for use in mental health settings. In contrast, the other category is health psychology tests. These are psychological tests designed to assess not psychiatric patients, but medical patients. I will point out again here that Dr. DeSorbio and I have a conflict of interest as we are co-authors of two of these tests, the BBHI2 and BHI2. Let's look at these tests one at a time. The MMPI is one of the best-known psychological tests. What is less well known is that there are now two versions of it, the MMPI2 and MMPI2-RF. The names sound very similar, but they're actually quite different tests. The RF stands for revised forms, but it's the newer one. The MMPI2 is a very well-known test, but it was old and needed to be revised. But even so, it remains quite popular. Both MMPI tests are good for assessing serious psychopathology, personality, and general psychiatric assessment. They're both complicated tests, producing up to 100 scores to consider. One of the greatest strengths of these two tests is the assessment of response distortions, various reasons why people may want to distort the information they are providing. This could involve faking good, faking bad, being acquiescent or wanting to agree with everything or disagree with everything or just random responding. They have some useful tools for identifying those tendencies. They also have some tools I like a lot for identifying thought disorder. Remember though that these two tests are actually quite different regardless of the similarity of their names. And some say the new version is more psychiatric and less medical in nature. Research-wise, the jury is still out about which is best for medical patients. Perhaps the new one in the long term will do best. Like the two MMPI tests, the MCMI-3 and PAI are both psychiatric tests designed initially to assess psychiatric patients. Again, all of these tests are standardized. The MCMI-3 has particular strength, though, with the assessment of personality disorders. If you have a patient who you think has a personality disorder, but you're not sure what type, the MCMI-3 is probably the best test. By the way, a new version of the test, the MCMI-4, is due out, I believe, in late 2015. Another strong contender is the PAI, another general measure of psychopathology, which is most remarkable for its excellent psychometrics. But all these tests, the MMPI tests and these two as well, have no pain scales, no measures of function, and while the MMPI-2-RF does have pain norms, none of these tests were originally designed to assess patients with pain. Nor were they originally designed to assess medical patients. The intent was they should assess psychiatric patients. In contrast to the psychiatric tests we've been discussing, the BHI2 and MBMD are two medical psychology inventories designed from their inception to assess medical patients. Although these two tests are both medical psychology inventories, the two tests are quite different. The BHI2 was developed primarily to assess patients in rehabilitation for pain or injury, but it also has community norms for the assessment of health more generally. In contrast, the MBMD was designed primarily as a measure for assessing general medical patients. That includes patients with cancer, heart disease, AIDS, and so on. Sometime afterwards, bariatric norms and chronic pain norms were also obtained. Let's look at these two tests more closely. The theory behind the MBMD is a theory of personality and coping. It tries to answer the question, how will an average, normal person cope with the onset of a medical illness or injury? People are different, and people will respond to a medical condition in different ways. Some will cope well, some will not. The MBMD tries to identify how a person might cope. Its strength is assessing coping styles, and also assesses health habits, what are called stress moderators, things that might interfere with recovery, as well as things like depression and anxiety. As a weakness, while it has pain norms, the computerized interpretation still uses the general medical norm group. In addition, in comparison to the other tests we've been talking about here, The MBMD has less in the way of validity assessment for assessing response distortions. The BBHI takes a somewhat different approach to medical assessment. This test is based on the biopsychosocial model that we've been discussing here, and in particular, its strength involves the assessment of factors that may contribute to the onset of chronic pain or delays in recovery during rehabilitation. The scales of the BBHI are laid out in a biopsychosocial format, so you have biological scales for pain, function, and somatic complaints, psychological scales for mood and personality variables, and social scales measuring conflicts with family, work, and doctors. The weakness here is there's no measures of other types of severe psychopathology like psychosis or bipolar disorder. All the tests we've talked about so far are longer tests that takes a half hour or longer to administer. There are also two shorter tests, the BBHI2 and P3, which take perhaps 10 minutes to administer. The BBHI2 is a simplified version of the BHI2, while the pain patient profile is a brief measure for patients with chronic pain, which has 3 scales and has a straightforward interpretation. Looking back, all of these tests that we've discussed have strengths and weaknesses, pros and cons, just like medical tests. Sometimes you want an MRI, sometimes you need a nerve conduction study. You order the test that will answer your question. So what does a psychological evaluation involve for a medical patient? Guidelines say that they should include a record review of the medical records, an interview of the patient, and psychological testing. I'd like to discuss now how we go about approaching assessment of the patient with chronic pain. Thus far I've been discussing our interpretation of the biopsychosocial model generally, but from this point on I'll be discussing how we do assessments with the BHI2 and BBHI2. This, of course, gives me a conflict of interest here, as I'm a co-author of that test. At the same time, this is an accepted assessment model. The following approach to assessment is based primarily on the references listed in the left-hand column here. Also note that our measures have been listed in multiple evidence-based treatment guidelines. Our measures have been reviewed 6 times by boroughs, and in federal court they've met federal standards of evidence and have been cited in federal court case law. Along the way we've performed a variety of other empirical studies, review studies, books, book chapters, and other works about chronic pain and pain assessment. So we feel we have solid empirical grounds for our approach. I still have a conflict of interest though, so please take that into consideration as I discuss the method we use here. If you recall our pain schematic here, this is what we are trying to assess. Various aspects of pain, of affect, stress-related symptomatology, helpful or dysfunctional personality traits or habits pertaining to pain. We also wanted to assess a patient's social environment and how that might potentially influence his or her recovery. The standardization of the BHI2 was based on about 2,500 psych evals administered to patients in 106 sites in 36 U.S. states, with none of these being administered by either myself or Dr. DeSorbio, my co-author. This allows us to gather 2 representative national norm groups, one representing the average American rehab patient and the other the average American community member. Now, these groups were matched to the U.S. Census data for gender, age, education, and ethnicity. The patient norm group was further subdivided by settings such as orthopedic versus pain medicine versus physical therapy, different insurance systems like Medicare versus work comp, by pain location like headache, spinal pain, by acute versus chronic, by valid administrations versus faking good and faking bad, and other variables. Along the way, we identified 70 patients who are thinking about suing their physician and 70 patients who are thinking about killing their physician, as well as a set of patients who are thinking about killing themselves. We thought being able to predict those things would be important. Test development was based on these norm groups. The BHI2 test results look a little confusing at first because there's a bunch of different scales and scores. Perhaps the best analogy, though, is to think of it like a CBC. You have a bunch of different values that you expect to see in the normal range, which in this case is a band in the middle. The length of the black bar shows how far a score deviates from the average, and ideally all the diamonds will be in the shade zone in the middle. You can also see the scores are arranged into biological, psychological, and social scales. So you have physical or biological symptoms like pain and functioning and somatic complaints, psychological scales like depression or borderline personality, and social scales like job dissatisfaction, family dysfunction, doctor dissatisfaction, survivor of violence, which gets after adverse experiences in childhood or in adulthood. Let's now apply all we've learned to some case vignettes. We'll begin with a case of a low-risk patient. Here's what the test results of a low-risk patient might look like. Like the ideal complete blood count, all the scores are in the middle range. This is the short version of the test, which looks at somatic distress, pain, functioning, depression, and anxiety, as well as a defensiveness scale, which measures either the tendency to exaggerate or minimize. Now, the BBHI-2 doesn't assess everything, obviously, but it assesses a number of critical variables pertaining to chronic pain, and as far as it goes, no risk factors were identified, and the overall risk level pertaining to rehabilitation was at the 24th percentile compared to other patients. As the 50th percentile is average risk, this means this patient is below average risk from a psychosocial perspective. Some patients are much more complex, though, so let's consider the case of a high-risk patient with back pain. Suppose you were seeing a 55-year-old male with chronic low back pain that had been refractory to all treatment. When patients are not progressing in care, and there's not an obvious organic explanation why, a biopsychosocial evaluation is often helpful. Let's explore what his results might be. On this testing, there are clearly some scores that are outside the normal range. To interpret this, though, we need to step back with this. You'll recall from our prior discussion that we talked about how chronic pain over time leads to central sensitization, and that this process gives rise to a number of chronic pain comorbidities. We are now going to try to assess those. What we want to know is how far is this patient wound up? You can think about the comorbidities of chronic pain as being of two types. One involves a variety of distress-related symptoms in the left-hand column on this slide. When we see all of these together, it's sometimes referred to somatization. These are all symptoms of the fight-or-flight response, also part of the hypothalamic pituitary adrenal axis. Pain is a stressful condition, and over the course of time, you start to see signs of chronic hyperarousal. On the BHI-2 and BBHI-2 tests, this is measured by the somatic complaint scale. Another phenomenon that is seen in chronic pain is widespread pain, as wind-up in the spine and central sensitization in the brain reduce the pain threshold. You start seeing pain in more body areas. The pain complaints scale assesses this pattern of widespread chronic pain. Now, in some conditions, like fibromyalgia, you may see both of these present, both a widespread pattern of pain and a high level of physical symptoms associated with distress. Let's return to the profile. And you can look at the numbers on the screen here. The high somatic complaint scale indicates the autonomic arousal type symptoms are at the 99th percentile compared to other patients. Pain complaints, the diffuse pattern of pain distributed across the body, at the 95th percentile compared to other patients. Now, interestingly, the anxiety scale is at a really low level. What could that mean? This is at the first percentile compared to other patients. Well, this is a somewhat different phenomena. Think of a patient who appears in the emergency room saying, "I am not anxious, this is not anxiety, I am having a heart attack." Some patients are absolutely sure this is not a stress problem, it is a physical problem, and they might present like this. But such patients may be overlooking input from some type of anxiety or mood disturbance. In general, emotions that are denied are more likely to be somatized. In this case, the patient is exhibiting a lot of pain and somatic complaints that he or she does not associate with anxiety. But nevertheless, this score is so low as to be implausible. Now also, point 4 on the profile here is defensiveness. There are no signs that this patient was trying to minimize or magnify. So even though the high somatic complaint score suggests the patient is chronically tense, irritable, has insomnia, appetite change, weight change, heart palpitations, and so on, which all sounds like an anxiety, the patient does not perceive himself as being anxious. But that will need to be explored, as that could be a substantial contributor to the symptom pattern here. Let's consider another case, which is more complex still. That is of the case of a high-risk patient with whiplash. For this, we will use the longer version of the test. This is a case of a 43-year-old female who had been an excellent employee over 8 years with the company. But while driving at work, she had a motor vehicle accident. The car was totaled. She sustained maybe a mild concussion, but more importantly, sustained a whiplash injury and a cervical herniated disc. 3 months post-surgery, she had no radiculopathy, but was very tense on examination and extremely pain affected in most areas of her body. While she had been an excellent employee, she had a history of intensely conflicted domestic relationships. This patient's BHI-2 profile provides a biopsychosocial analysis of her complaints. As you can see, there are a lot of scores outside the average range. Let's look at the high scores first. On this profile, both somatic complaints and pain complaints are high. Signs of wind-up. Diffuse pain and a high level of comorbidities associated with chronic pain. The patient was reporting a high level of muscular bracing as well as a high level of depression, and 2 personality concerns. Borderline personality traits at the 98th percentile, and dependent personality traits, also high. There was a history of substance abuse. There was a high level of family dysfunction, a high level of survivor of violence, that's adverse traumatic experiences, and a high level of job dissatisfaction as well. Now, this had previously been a sterling employee, but it turns out there were conflicts over her light-duty restrictions, and this had soured her relationship with her employer. There were also some low scores. She was low on functional complaints, which meant she was not complaining of disability. She was functioning okay. There were low scores on hostility. She had a problem expressing anger. Low score on chronic maladjustment, which means she's an overachiever. And a low score on doctor satisfaction mean that she really likes her physician. Remember, though, this patient has borderline personality traits, which means they can love you until they don't. The first time you say no, there may be a problem. Here is the BHI-2 analysis of the patient's pain complaints. In the red, you see the patient's complaints versus blue on the right, which is a national sample of patients with whiplash. The patient reported pain in 10 out of 10 body areas, with a pain level of 10 on a 10-point scale in 3 body areas, and a pain of 8 in 3 more body areas. Interestingly, the highest overall and the lowest overall pain in the last month were a 10, so she's saying her pain never changes. Remember that? Also, she says her maximum tolerable pain, how much pain can you tolerate and still work, is a 0. So she wants to get all her pain down to a 0 before she resumes her normal activities. That's an impossible expectation. We can also examine BHI-2 critical items. Here we see the patient reported having been raped and sexually assaulted at times in her life. Now that's good to know, but it's also very private information, so you need to safeguard that. She reports being addicted to prescription drugs, and she reports that she's been suicidal. Let's review what we've learned. The patient reports extreme pain with diffuse pain complaints. It's invariant, below average pain tolerance, signs of somatization and wind-up, and she's prone to muscular bracing. She's reporting severe depression with current suicidal ideation and a remote history of a suicide attempt. She has difficulty expressing anger and is prone to somatizing it. She also has borderline dependent personality traits, and while she has no prior history of substance abuse, at least she's not reporting any, she does feel that she's currently dependent on her opioid pain medication. Previously in her life, she was a high achiever in vocational and educational settings, but had a long history of dysfunctional love relationships with domestic violence. Elsewhere in her BBHI-2 profile, it was revealed that she's not interested in compensation, and she's not litigating. She does, though, have an intense need for attention and sympathy, and so far has a strong bond with her physician. Her composite psychometric rehab risk score turns out to be at the 99th percentile. Again, all of these results are based on the BBHI-2 scores. So what should you do? Suppose you try a biomedical intervention. You say your symptoms are impossible. This is all in your head. It must be pre-existing. You're an addict. No more opioids. You need to stop complaining and just go back to work. Although this has been an excellent employee over the last 8 years, she also has some borderline traits, and I would expect this patient to be humiliated and furious, perhaps attempt suicide with the medications you gave her, maybe blame you. Probably hire an attorney because she would be so angry she'd want revenge. She wasn't litigious, but probably would become litigious if she was insulted, and she would never go back to work. This approach just wouldn't work. On the other hand, you could try a biopsychosocial intervention. It might go something like this. Your symptoms suggest what's called a chronic pain syndrome. There's a number of things we can do to help you with that. On your test, you said you were concerned about your use of opioids. I am too. I think, though, that we can develop a more comprehensive plan to help you get better, and I'm invested in doing that. One of the things I tell my patients is that all treatments basically fall into 4 categories. There are surgical or interventional techniques that we can use, medications, various forms of physical therapies, and also behavioral medicine, that things that you can do to manage your own condition. Unfortunately, we really don't have time to go into this, but let's very briefly consider psychological treatments for pain. If you recall our diagram, for each of these areas there are psychological treatments. There are cognitive therapies for thoughts, biofeedback and relaxation trained, sleep hygiene trained for arousal, affective therapies for mood, and so on. You might say something like this: I'm concerned about your neck, but I'm concerned about you as a person too. Now, we're going to do the medical tests and treatment as indicated, and I'll do whatever I can to help, but you also need psychological support. You are depressed, and I'm going to get you help for that. Now, you should monitor the patient for suicidality and refer to a pain psychologist for treatment while weaning off the opioids. You might want to get her support first before you try weaning her off. And also refer for mental health treatment outside of the work comp system for relationship issues. There is an important study that shows that even when patients are depressed and have personality disorders, they can respond to appropriate care for pain-related disability. But can this really work on a large scale? Well, we tested that. Over 20 years ago, the Colorado Workers' Compensation System legally mandated the biopsychosocial model with a number of biopsychosocial treatment guidelines. Following that, we gathered data on 29 million injured workers in 45 U.S. states over 15 years, and we compared workers being treated by a biopsychosocial model versus ones that were treated in the biomedical model. So, how did it work? The concern was that including psychology would drive up the cost, it would open Pandora's box, and would just make things more difficult. It would increase cost and increase disability. So what happened? Here are the results. Here are 15 years of medical inflation showing the nation in blue and Colorado in red. As you can see, over 15 years, the nation had 202% inflation, Colorado 68, a 3-to-1 difference in terms of medical inflation. If we look at indemnity costs, here Colorado's advantage was even greater, showing an almost 4-to-1 difference in cost increases. Thus, the biopsychosocial model showed evidence of providing better care at less cost. So how much did this save Colorado? The estimate was that in 2007 alone, this saved Colorado about $859 million. It was better care for less money using the biopsychosocial model. So in conclusion, the biopsychosocial model is the accepted model of pain. Behavioral assessments and treatments have been shown to be safe, effective, economical, and an important component of best care for the patient with chronic pain. Thank you.